All right. Thank you so much, Jeff Koinange, there for taking us through the first part of this show. And like you hear from the voices there, they're talking about the challenges they've had to go through and the hope that the new health laws, the new arrangement is going to be part of the solution. Of course, many challenges exist in the health sector. And to help us have that conversation, we have a panel of ladies and gentlemen. I want to introduce them, starting with Muthomi Njuku, who is the governor of Tharaka Nithi County, but also the chairperson of the Committee of the Council of Governors on Matters Health. We have Nakhumicha Wafula, who is the Cabinet Secretary for Matters Health Affairs in this country. We have Governor Stephen Sang, the governor of the County of Nandi, but also a member of the Council of Governors Health Committee. And we have Nana Kilemi, who is the founder of Needy Cancer Health Initiative, herself a cancer warrior. And also we have one Martin Wanyonyi, Member of Parliament to Obuye East, but also member of the Health Committee at the National Assembly. Good evening, ladies and gentlemen. And we're here to have that conversation to sort of try and answer the questions of those two persons that have spoken before us. Let me begin with you, Waziri, because just, I think it's a week ago that we had the judgment of the Court of Appeal that sort of said that the orders that had been put by the High Court have now been lifted, and the implementation of these health laws can continue, apart from a few issues that are still of contention that the court has said that they should not be implemented as they are at the moment. So where are we in as far as the journey of transforming the health sector is concerned going into this phase?
Thank you, Sam, and thank you, Citizen TV, my colleague panelists and viewers, especially the people from here, Kibera, Sateni Sana. I'm happy to join you this evening to express myself and give hope to Kenyans that after we appealed the court case, we finally got a reprieve when the case was, the suspension was lifted, except for 3 sections of the act that were not lifted. So what that does is that it paves way now for us as a ministry to implement universal health coverage. And for many who may be struggling with what universal health coverage means, it simply means that every Kenyan can access quality health services from wherever they are, without suffering a financial loss. And that is what we intend to achieve with the laws that we put into place. That is the Social Health Act, the Digital Health Act, Primary Health Act, and the FIF. So now, as a ministry, we have started activities in earnest to ensure now we go into implementation. And for us to implement the act, we need to have regulations. So we have already gone ahead and advertised for members of public to come out and stakeholders so that we participate in a public participation exercise so that they can give us their views on the regulations that we have put in place that will assist the ministry now to operationalize the acts. Yeah.
Mm-hmm. And where can they get these regulations?
The regulations are available on the ministry website. They are available on the website of the National Health Insurance Fund. They are available in hard copy at the ministry headquarters, and we want to ensure that we also place copies in the different region offices for the National Hospital Insurance Fund. And we have a whole information desk at the Ministry of Health. Anybody needing help then can get in touch with the Ministry of Health. We can share copies. And I think what we are going to do, since I have my ministry officials here, is that we can also share copies with the media houses, so that should anybody need, then they can also access it through you. Yeah.
And Governor, the last time we spoke, we were still waiting for this phase of the reforms in the health sector. And now with these regulations out, I don't know what are the efforts, for instance, for your county or even the Council of Governors to bring to the fore the issues that are contained in those regulations to the members of the public for them to make an informed contribution?
Well, first of all, let me thank you for giving me the opportunity to be here to contribute to the other panelists. I want to tell the members of the public that those who have gone to hospital before and they have exhausted their NHIF and they have had to go back to their farm to sell a goat, you have all the reason to support this now, especially because there will be no issue of exhaustion when your disease is advancing, because the other health insurance, the second and the third one kicks in. This information definitely is being shared with the public, and our biggest soldiers in this journey are the people who are taking of the primary health care, who are seated in this room, some of them, the community health promoters, who are very good training, and they are our first line of defense. And we intend this information to get to all the members of the public, those who feel they don't get sick and don't feel they don't have to contribute, and even those who are sick and who usually often uses NHIF. It is important that all of us get involved, and that is our message as the Council of Governors.
For you, Governor, from Nandi County, of course, the law and the regulations say that it is mandatory for any person in Kenya to make a contribution, for instance, to the social health insurance fund. How much of this is known to your constituents?
Thank you, Sam. I think one of the things that I think is important to understand is that this entire reform package, started with the laws. As we even talk about the regulations, we know for a fact that the process of enacting the 4 legislations were undertaken. And there was already public participation around the enactment of those legislations. We are now getting into the second phase of that engagement with the public through the regulations. What, of course, we think is important is that beyond the public participation that happened on the enactment of the regulations, the Ministry of Health must also work out a formula of dissemination of this information in simpler versions, because I think a lot of misinformation being shared around would be dealt with simplified pamphlets that we can be able to share. And we have a huge army of over 100,000 CHPs. We also have, within our own facilities across the 47 counties, those facilities can be centers of sharing that information. But I think, Sam, in summary, this whole reform package around the healthcare sector addresses the very core issues of where we have been. The concerns that were raised by the 2 ladies over there, in terms of, for us as counties, we think that this reform package from the Acts of Parliament, the 4 of them, to the regulations, will address, 1, the focus. I think we are shifting the focus to primary health. 2, it's addressing one of the major challenges within the health sector, which is financing. If you look at, the FIF Act and the Social Health Insurance Act, it addresses the question of financing of health. We think that this is going to be a game changer within the health sector. We also appreciate that these huge changes will come with teething problems, but we must develop sufficient courage as a country to travel that road. It might look, uncomfortable for some of the players. We know the current system, we have people who are victims, like the 2 ladies as they spoke. Clearly, they have had challenges. But there is a team of stakeholders who benefited from that skewed process. And for them, they will not be excited about this reform agenda. So we must all be careful.
What do you mean with that?
This system, the current system, has benefited. For example, I will tell you openly, from the county government perspectives, the current NHIF model has favored private service providers, as opposed to as opposed to public facilities. If you went to look at the disbursements from NHIF, it is going to be clear that private health facilities were more funded than public health facilities in terms of the quantum, but also in terms of the speed. So we think that this entire reform package is going to address some of those things, and you will definitely have certain quarters that are not happy with it. Okay. But I think, as I said, we must develop sufficient courage as a country to travel that road and be able to reform the health sector.
Governor, we'll come back to that later, but allow me to skip you, Nana, and speak to Mheshimiwa Wanyonyi here, because you sit at the Health Committee in the National Assembly, and there's processes that are required to be taken through for delegated legislations. For instance, we are talking about the regulations. From what you know, what is the process like? Because the ministry has released the regulations for public participation. What should happen before they become effective?
Thank you so much, Sam, for also inviting me here and my fellow panelists. I think, one, we've had a discussion as a country for decades in terms of giving the people of Kenya a comprehensive health care. I'm happy that when we took over this administration, for 1 year, we've been able to deliver the 4 laws that we are talking about. And the regulations that, of course, these laws, they cannot implement themselves. We require the regulations that Waziri is talking about, which are going to set the necessary guidelines in terms of the implementation of these particular laws. Of course, where it is now, it is still with the executive, it's still with the ministry, and the ministry will have to do its part the way Waziri is talking about public participation and all that, which finally then they will find themselves to National Assembly. And so, as it is today, it's still with the ministry. But the most important thing, I think, for us as Parliament, and 13th Parliament, and the Health Committee, led by my friend Honorable Pokose, we are committed, because the people of Kenya have always wanted this, have always wanted a comprehensive package. When you listen to the 2 viewers, the 2 victims, you'll appreciate just how the previous scheme has been discriminative.
Okay.
That today, in the course of treatment, you lose your cover. And so we want, as Parliament, to ensure that we leave no one behind. Everybody, whether you are employed, you are not employed, whether you are young, you are old, whether you are severely disabled, you are not disabled, you are able to get a cover that is not only comprehensive, but is also quality.
Right.
A cover that is also affordable, a cover that is also sustainable. So I think really we are hoping and waiting eagerly for the regulations from the executive, which for us as Parliament, we will do what we can to ensure that they are also processed in good time, so that then the ministry and the government can move forward to really now implementing and actualizing the 4 laws, especially the 3 funds that are established within the health insurance.
We'll get to that, Mheshimiwa. I just wanted to mention that we are also here with members of the community of Kibra, and of course, some of them are community health promoters. We have people in the border sector. We have religious leaders. We have village elders, as well as chiefs, persons living with different conditions, but also government officers that are here and leading CEOs or chief executive officers from different departments. They are here to help us have this conversation. And now let's get into the nitty-gritties of this work. And we have just heard from 2 persons that are dealing or fighting cancer. And Nana, you've been there. You've also dealt with a lot of people that are also in that space. Maybe you can help us in more detail understand how NHIF has worked for most persons fighting cancer, or even other conditions, if you may.
Thank you so much, everyone. Thank you, Madam CS, our governors, and people of Kibra. My name is Nana Kilemi. I'm a breast cancer champion. I just came out of treatment 6 months ago. I'm also a founder of an organization which is currently helping the most needy or the poorest cancer patients in our entire country, Needy Cancer Health Initiative, whereby for the last 6 months, I started this when I was still sick. We've covered like 70 patients, fully paid for NHIF for 2 years, and we also give these people food. So let me share some light, and I really, really want to thank you, Madam CS, because for me, I tell people I'm a product of NHIF, and I believe in NHIF 100%, and I believe
in this of our government 100%, because what NHIF did for me today, and so many other people who are behind me who have been touched by this monster cancer will not have survived. NHIF covered for me 6 sessions of chemotherapy, 20 sessions of radiotherapy, full, part of CT scan, PET scan, which is extremely expensive, and now I'm on a long treatment of 10 years called hormone therapy, and that cover fully pays for my medication. And now I'm going for my breast reconstruction, and this cover has fully paid for. So we are very, very grateful, Madam CS. We are very grateful to our government, because this has been a real deal breaker. Hence, that is why me and my friends who are sitting there, most of them, believe that this transition will really, really benefit our people, because currently in our database, we have over 1,000 cancer patients who are locked in homes without attending to treatment because, one, they have no money for NHIF. Number 2, they have no money to attend to treatment on cash basis. I believe this transaction will help save so many lives, because all these people will be touched. We don't have to worry about the blood works which you have to do before chemotherapy. You don't have to worry about the CT scan. You don't have to worry about the biopsies. We don't have to worry about the cut number of chemotherapy session. We don't have to worry about the radiotherapy. It is going to be a whole set, which is going to help so many Kenyans. And I'm telling you, my fellow Kenyans, please, let us embrace this so that we can save as many lives as possible, and more so on cancer, because cancer is a real menace. Every day, I talk of breast cancer because we are losing between 5 to 6 women on breast cancer, and we are not mentioning other cancers. What will happen, Sam and Madam CS and other distinguished guests? Today, if we don't embrace this new change, every day each and every one of us is either directly or indirectly affected. I'm very sure every one of us is in one or the other WhatsApp group. Now, you have to contribute 20, 30,000 because cancer is not cheap. What about we embrace this, then every one of us gets covered.
Okay. Nana, let me ask you, so
yes,
for
please.
the services that you got for your treatment,
yes,
how much did you have to contribute to the NHIF?
I only contributed 12,000 for 2 years. Because each year, NHIF is 6,000. Each month, for people who are employed, is 500 bob.
So you are paying 500 shillings per month?
Per month,
okay,
yes.
all right.
Yes.
I'll get back to you, but Waziri, help us understand here the difference between NHIF and SHIF and why this shift. What exactly is the major difference between the two?
Thank you, Sam. One, before I explain the difference, is first to explain the difference in the model. Why are we changing how we deliver healthcare in this country? The system that we have had predominantly has been curative in nature. That is a system that anticipates and waits for you to get sick, then it treats you. What we are moving to is preventive and promotive in nature, so that we try as much as possible to prevent citizens from getting sick. We try as much as possible to promote good health amongst the citizens. And that is why we are doing it with our community health promoters, that they get into households and shift people's thinking that you don't have to wait until you're sick, that if only you engaged in proper sanitation, there's something that you're going to avoid in terms of getting sick. By the way, the high rate of mortality for under 5 children is because of sanitation, that the parents are not able to practice good sanitation practices and hygiene. Look at when we had COVID. Many hospitals did not have as high number of patients. Why? People were washing hands, people are wearing masks. Simple acts, but they reduce the level of disease within the community. So the shift that we are having now is to say, can we move that direction? That we spend less in terms of how much more. Nana has not told you, but most of treatment, especially for cancer, if you are found to have cancer at stage 1, and this afternoon I was having a discussion with my CEO who is here, you will spend about 300,000 shillings to be treated, especially if it is surgery, stage 1 cancer. And for most cancers, if they are found at stage 1, take cervical cancer, breast cancer, a simple surgery, and you get healed. But if you stay with the sickness and you get to up to level 3, level 4, then you will require much more complicated in terms of treatment. That will be much more in terms of cost. So what is the problem with the current NHIF as it is? One, it has a structural problem that when it was put in place, it was largely to cater for people who are salaried. That it was structured in a manner that you who is on a payroll, you have a pay slip. At the end of every month, there's a deduction from your employer to remit to NHIF. So we came back, there was an amendment then that said it is mandatory for everyone to pay, whether you're on payroll or not on payroll. And remember, we only have about 3 million Kenyans on payroll. About 2.5 million households are on payroll. The rest are not. So how do we ensure that the remaining 10 million households of Kenyans are covered? How do we ensure that we are able to take care of their health? How do we ensure that they are able even to pay? Because not paying on payroll doesn't mean that you necessarily don't have an income. We have people who are not on payroll, yes, but they do businesses, they have an income. They are entrepreneurs, they have an income. We have mama mbogas, they have an income. So what we have done in this, now the social health insurance fund, is to ensure that then we are able to identify, first of all, each and every Kenyan. Number 2, we are able to know or to identify what is your level of earning, what is your income. Number 3, then we are able to have an equity ratio in terms of how much then you are expected to pay towards your health care. And number 4, that we want to bring in everyone on fold, that those who can't pay, who have no capacity or ability to pay, the vulnerable that we have, the disabled that we have, the very old that we have within the society, but we have a huge number of people who are able to pay. Then we put together resources so that then we can take care of those who are not able to pay. So that is one of the shifts in the social health insurance fund. The other shift, which you have heard from the people who have spoken, that NHIF did not cover at 100%. For example, the patients on cancer, there's what is called the blood works, which is very important. Before you start any treatment, we must first check what is it that will work for you. That is not covered. Other checks like CT scans, there are some CT scans that you will be covered for, others will not be covered. If you will require your treatment for a long time, you will reach a level where NHIF does not cover beyond that. So there are limits. What we are doing in the new law is that then there are no limits. If you have cancer, you have cancer. You'll go through the primary level, go to the secondary level, where then your social insurance kicks in. But if you require treatment beyond the secondary level, then you go to the tertiary level, which is where now you'll be covered by the critical emergency and chronic illness fund. That means that your disease is covered from the beginning to the end. There's another change, that under NHIF, we have congenital conditions that ordinarily are not covered, even with private insurances. Many of them, you will see them ask you to fill a form so that you disclose what other conditions that you may have. Some may be congenital. That is the way you are born with a certain condition. They are not covered. But you're saying these are Kenyans, you see? The children did not apply to be born with a certain illness. So now we are for a package which will take care even for congenital illnesses. Screening, that is prevention. Right. The current NHIF doesn't cover that. That if you say, okay, I'm not sick, but I need to be checked whether I'm okay or not, NHIF will not cover. But under a social health authority, now we are covering for screening, We are covering for wellness so that people can check themselves and just ensure that you are living healthy. Yeah.
Right. You've described the differences in terms of these services.
Yes.
Let's talk about the financing, because I hear you saying, I don't know why you smile, I hear you saying that there are certain instruments that will be used to check how many people cannot pay and how do we pay for them. You're also saying that only 3 million people are on payroll, only 2.5 million households are on payroll. And you have introduced the percentage. For the first time, we have it in print, in the regulations, 2.75% of gross salary or wages. First of all, how did you arrive at 2.75%?
We looked at, by the way, the ministry has actuaries. Are they called actuarists? Yes. People who are trained to look at numbers and make projections. We have those within the ministry. We have those within NHIF. So first, what we did is to look at the baseline, that in the existing NHIF, what were the ranges of payment? And when we looked at it, the person who was paying the most is anybody who was earning below 10,000 and below. They were paying up to 5% of their income to NHIF. The person who was earning the highest, let's take for now, I think the highest paid public officer would be the president himself. With his salary, the maximum that he pays to NHIF currently is 1,700. And his salary is way 1 million plus, you see? So that makes it that he pays 0.01% of his income to NHIF. It then disadvantages the person with a low income. This is somebody earning 10,000, they're paying 5%. This is somebody earning $1 million, they're paying 0.01%. So then we looked at an average of this. If we were to average. Number two, we also costed our healthcare. We know that at the tertiary level, how much? And from our costing, we need about 46 billion to be able to provide services at the tertiary level. We costed our secondary level, that is level 4 and 5. We need about 130 billion. Then we costed our primary level of health. That is the community health promoters, then level 1 and level 2. We need about 80 billion. So based on that costing, then doing the actuals, we arrived at 2.75% of income. If every Kenyan was able to pay that, we should be able to take care of the whole healthcare.
So 2.75% of, is it the gross national income?
Yes, of the gross income.
Okay, so let's talk about that, because we've had these conversations, and in December we spoke to the president and he said that it is 2.75%, yes, but nobody says there's no caps. For instance, if you work for a corporate organization, a private sector, and your salary is 10 million shillings, and you're deducting 2.75%, are you going to deduct 275,000 shillings to the Social Health Insurance Fund every month?
That is our suggestion. And that's why we've said we have put this out to public participation. You know, you're saying that, are you going to pay? But you've not asked that person. Suppose I'm the one. For me, who is a minister in charge of healthcare, I know what it means to have everybody being covered. I do not have a problem paying 2.75% of my income. But should we speak to the public in this exercise that we are calling public participation? And by the way, we are going to move around the regions. I am going to move around even myself, because I want to hear for myself what is it that Kenyans are saying. If they say that 2.75% is okay and they agree with us, so be it. We'll take the views as they have come. But should there be Kenyans who say, okay, maybe you need to cap it at something, we'll still listen to that. Then we come back and do our report. Mheshimiwa didn't mention, but immediately we finish with our regulations, we'll take them to a committee in Parliament, the one on delegated legislation, that will review what we'll have submitted, also go through what we receive from public participation, and then subject it to the House before we can gazette. So it depends. Okay. And really...
So you're saying if the feedback from the public participation, it says that let's cap it.
Yes.
What would be an appropriate cap for the ministry to still offer the services you're talking about?
We will have to do workings, but we have been doing projections at cappings at different levels with our actuaries. We have done scenario mapping. We've said, for example, if we were to cap it at maybe 5,000, what would it look like? Because at the end of the day, we have to cap, but also be able to meet our bills the way I have told you that we have costed. So we will not just agree to just cap, just like that. It has to make sense that we cap, yes, and we'll raise revenues to be able to provide services.
Right.
Yeah.
Governor Muthomi, there are some Kenyans who may feel, for instance, they've been making the contribution of 1,700 shillings, which is the maximum currently on NHIF, but when they go to hospital, the sort of services they get is very limited. And that is at the back of their mind, even as they come to the public participation. So what convincing power must those in authority use to tell them that actually we're opening it up? We want you to pay more than 1,700, to pay 2.75% of your salary, whatever it is, to manage to access these services?
Well, the biggest problem with the NHIF as it has been structured before is in implementation. In terms of the difference when you go to the private hospitals and when you go to the public hospitals. There's been a big problem in terms of costing for the diagnosis, the treatment, the tests and all. And that is why I like the fact that even before we brought the Social Health Insurance Fund to replace it, the rots, the inconsistencies that have been there have been pointed out up to some extent. CS has been doing a very good job in bringing this thing to the fore. I remember the other day, even my county, some of the doctors who were involved in that were exposed. And that is what Social Health Insurance Fund must cap. That we do not have a system that allow our patients to be fleeced by doctors or those who own clinics who retain our patients and make them pay more simply because NHIF is paying. And it has been a very big problem in what has been seen to be disadvantaging the public hospitals. And it is evident in the fact that 90% of the health facilities in Kenya are public. Well, the 10% what usually treats our people in public and probably charge more. If you look at the claims of NHIF, they have been claiming 90%, while the public sector claims 10%, despite being the reverse. What is the reason behind that? Everything that is done in the private sector is costed. The doctors, the diagnosis, the medicine, but in the public sector is normally capped because most of it is subsidized because it is taxpayers' money. And that has been the biggest problem. That is why when you go to the private hospital, which most of the time has the commodities and it has the doctors in place because, of course, they look at the element of the profit factor and attracting clients. Our people normally feel they'll get healed in the private hospitals better than our public hospitals. While in actual sense, when you look at the doctors mostly who usually appear in private hospitals, I know they are watching me and listening to this, and I would like them to deny, they are actually doctors who work for salaries in public hospitals. They are the ones who do the rounds there. And they get to pay more there. In fact, sometimes they refer you. Why do they refer you? Because the CT scan is not working, the medicine is not available, the X-ray has an issue. And what does it have an issue? The issue of funding to the public sector vis-a-vis the private sector. And that is what the Social Health Insurance Fund should seek to actually be able to resolve. And all the Kenyans, whether you're being treated in the private sector or the public sector, you should be able to have the same form of treatment in the Social Health Insurance Fund.
Governor Sang, you spoke about some people that have been benefiting unfairly. Even as you give us more details about that, when you look at your county, and we know that obviously the salaried will pay the 2.75% as per the regulations, but again, when you look at the population, do you know the number of people that you'd have to now step in and pay for them? Because it says that for those that are not able to afford, it will be a shared responsibility between the national government and the county government. For you, what are you looking at in terms of numbers?
Thank you, Sam. I think it would be difficult to say that, in terms of the actual numbers now. But I definitely know, for example, that the salaried people in my county are small number, but I have a lot of farmers who are members of KTDA and they supply tea to various factories. And these farmers are not on NHIF, because the current model does not, adequately address that. So if we were, for example, to work around, KTDA and ensure that all the farmers who are taking their tea to the various factories are captured at that point, all my dairy farmers, 80% of them are members of dairy cooperative societies. We can be able to structure, an arrangement where we can be able to work and get their subscription at that level. We have coffee farmers and all manner of, we have also for example, boda circles. We sit down with them, they pay us their sticker fee. We know what that means. We can be able to engage with them and provide a mechanism that we can be able to get, their contribution at that level. So I think if we did a proper mapping, we will definitely be able to address that. Okay. So for me, I think let's go through this process. As I said also, we must just understand, and I think I want to respond to even what Mudomijuki mentioned, that this is not just about the 2.7%. It's really the entire reform package. For example, part of those challenges that people would come to our health facilities and they do not get all the services that are available is that also we have not been able to ring-fence the resources within the health sector. That is why one of the laws on one of the legislations here is FIF. What does it mean? It does ring-fence the resources being generated within our health facilities for improvement of the facilities at that level. Okay. What that would mean is that, for example, a county like mine, that my percentage of my resource percentage is 33% to health. With FIF, I am able to increase that probably to around 40%, which then means I have resources to continually invest. Right. Again, in terms of we need to standardize, because part of the other challenge that people would run, their cover would run short or dry at NHIF, is that you have this pot of resources available, and the drawing there has to be integrity in the process of drawing these resources. If a C-section in my county referral hospital in Kapsabet, I am being reimbursed, for example, 7,000. Then in a private health facility across the fence, their reimbursement is about 20 or 25,000. Clearly, all these resources are coming from, the same pot. Right. We will drain these resources. So we must also be able to standardize, the provision of health services. For example, if you are being treated for malaria, it should be the same whether you are in a public health facility or in a private health facility. Okay. Let's standardize and ensure that we are able to ring-fence these resources. Finally, for us, right, whether we like it or not, these people who are not covered by NHIF, the people who will end up having to support as a society would still be the ones who are paying, who are salaried. If you go to the Arambes in the villages, the chief guest would be a teacher, a principal in a high school. You have to come and support. Why don't we dignify the provision of health so that we do not have to come to an Arambe and appear to be generous in supporting this patient? Why can't we dignify that process by ensuring that all of us pay equitably? Right. And by the way, as I pay 1,700, which is for a governor, that would be like close to what the Waziri said, 0.1%. And my Boda chairman at Namgoi, Boda Shed, would be paying 500, which would mean that would be about 2 or 3% of his earnings. Yet my family will be covered the same way that border person is being covered, receiving the same service for the same cover. Yet I am paying 0.1%, he is paying 5%. Let's just be fair as Kenyans and ensure that we just dignify this entire process and ensure that people can be able to get services.
All right, Governor, you may...
Allow me to say something on what Governor has said about the tea farmers, the cooperatives, the milk and all that. In this act, what we have done, You know, the tea farmers, the ones who take their milk to the cooperative, they will get their dividends once a year. And once they get that dividend that year, if they are not able to pay for their health, then the rest of the year, they are not able to contribute. So what we have done in this law is that for such kind of arrangements, then we have made provision so that they pay one-off within the year. That you receive your dividend there and there, you pay for your social health insurance, and then you're covered for the rest of the year. Wait until the next dividend, then you also make another payment. Or for those I have seen, a citizen has projected somebody who has won a jackpot on something. You know that it's called what? This one that you're advertising all the time. Betika, or whatever it is.
Shabiki.com.
Or Shabiki.com. So once you get your Shabiki.com, then the first repayment that you need to do is to Social Health Insurance Fund. So that should you have issues that Shabiki.com thing you don't get again, you are covered for the year.
All right, Governor, I just wanted to say that when you say FIF, it may be confusing. So let's just say it in for Facilities Improvement Fund.
Yeah.
All right, and I want us to take a short break. We're still here at Makina Social Hall. We have so much to cover, so much to talk about, including not just the contributions, but also how do you standardize the services? Because you may have the money, but what is the quality of service? We're here. We'll be back shortly. Jeff.